أهلا فيكم جميعا. اليوم إن شاء الله عندنا 2 tutorials بإذن الله ما هي طويلة. عندنا Identifying Sick Child والorganophosphate poisoning. So why we concentrate on the care of the acutely ill or injured child? ليش مركزين على هذا ونعطيه tutorial خاص فيه؟ Because their management is slightly different. The acutely ill child requires rapid evaluation different than used to assist the well child or the child with a chronic or minor illness. فنوع evaluation يختلف لما تجي الواحد stable في الكلينيك ولا واحد عنده minor injury. It centers on the rapid identification of physiologic derangement in organ system function rather than the immediate development of a differential diagnosis. الشيء الثاني الهدف الاسسمنت الاساسي اننا نعرف الفسيولوجيك ديرينجمنت، وش الاشياء اللي بالفسيولوجي تغيرت عشان نرجعها للطبيعي، اكثر من تركيزا على diagnosis والديفرنشيال diagnosis. فالابروتش يختلف كذلك. The goal of this efficient assessment is to triage or to identify children at risk for critical illness or injury. نفس الشيء اللي يسوونه في الطوارئ، يسوون triage للبيشنت، هذا لازم يشاف الآن، هذا يشاف بعدين. نفس الشيء أنت تسويه لما تشوف acutely ill child. Because suspicion of critical illness warrants immediate management such as resuscitation, such action may need to be based on very limited information. لنفس الشيء كل واحد عنده abnormality تحتاج تدخل سريع، ما عندك وقت انك تسوي assessment كامل لكل شيء، فلازم تكون محدد وفوكست، تاخذ المعلومات فقط اللي تحتاجها عشان تبدا المانجمنت. في الchildren لما نشوف الكارديك ارست واضح في اكثر من precipitating condition، يا منها respiratory or circulatory، يعني اهم شيء انه جاي من الكارديوفاسكولار او من الريسبيراتوري سيستم. في الادلت الكارديك arrest are mainly due to circulatory ولا cardiovascular derangement. في البيدياتريكس لا العكس، في البيدياتريكس most of the causes of the cardiac arrest are due to the respiratory cause. كيف يصير هذا الشيء؟ أول شيء يبدأ الواحد يصير عنده respiratory distress اللي هو pending respiratory failure، يعني إذا ما عدلت المشكلة اللي هنا فالrespiratory failure is pending، يعني بيصير. إذا ما تحسن الشيء هذا he will go into respiratory failure. If respiratory failure is not corrected بيأثر على الهارت and would cause cardiopulmonary failure, and then cardiopulmonary failure would cause cardiac arrest. Circulatory المajority of children اللي هو shock، يا اما نسمي الشوك نقدر نقسمها لقسمين. early on it is a compensated shock. compensated معناته البادي يسوي ميكانيزمز معينة عشان يمنع هبوط الضغط، واضح؟ فالcompensated it is with the normal blood pressure. decompensated يعني خلاص الجسم مو قادر يقاوم هذا الشوك، يصير عندهم low blood pressure. فإذا قلل ضغط الدم يقل التروية الدموية للهارت ولللنغ، فيصير عندهم cardiopulmonary failure and then we'll go to the cardiac arrest. The cardiac arrhythmias is very rare in children. The cardiac arrhythmias it could cause shock and it could cause cardiac arrest immediately. But they can go through this line or it would immediately cause cardiac arrest زي بالA system. زي ما قلنا cardiopulmonary failure rare spontaneous event in children. It's typically the end result of progressively deteriorating respiratory or circulatory function. Respiratory is more common. Once it happens, the cardiopulmonary arrest, the outcome is poor. 75% will die, and out of the 25% who will survive, 75% will have permanent disability. Generally speaking, the outcome is very poor. Our goal is really to prevent arrest والcardiopulmonary failure from happening. So you should act early, identify these states, and act on them to reverse them before cardiopulmonary failure and arrest happens. So how we categorize our patients? The initial evaluation of the acutely ill child requires rapid cardiopulmonary assessment, and it takes less than 60 seconds to complete. Just very quick. اللي هو pediatric assessment triage أو triangle PAT أو تستخدم ال ABCDE approach. ال ABC اللي appearance هذا غير ال ABCD اللي هو airway breathing circulation. فال A B breathing, C circulation. A appearance, is the child diagnosed or not? Is he conscious or not? هذه بس ال appearance. ال walk breathing, is there signs of respiratory distress or not? Circulation, في pulse ولا ما في pulse. فهذه أول ما تدخل على المريض, you can do this in less than 60 seconds. If any of these is affected, it means this patient is critically ill. هل في another tools that we could use? Yes. طبعا واحد من التقسيمات اللي ممكن نقسمها to triage the patient صوت مين جاي؟
This is the Medicast Podcast Extra Slideshow. We'll be looking at the pediatric assessment triangle and some of the things that it can do to help you in your assessment of pediatric patients. So what are we talking about when we look at the pediatric assessment triangle? First of all, it's something you're going to use in your initial assessment, and it's easy to use. It's before you even get to the patient. It's non-invasive. You don't even actually touch the patient when using the pediatric assessment triangle. And that's one of the things that makes it so amazingly valuable for assessing. Pediatric assessment triangle is based on you using 3 variables to determine whether you have a sick or not sick patient. And by sick or not sick, we really mean critical.
طيب بدون نفتح اليوتيوب فيديو للبات assessment. You could Google it if you want to get more information. من الcommon triaging system اللي هو triaging system اللي يستخدمونه emergency departments. في emergency departments زي ما تفهم في triaging system. هدف triaging system انه يحدد لك البيشنت طبعا كاتيجوري تسمون كاتيجوري 1 2 3 4 5 اوكي. كاتيجوري 1 اللي هو resuscitation ف needs to be seen right now. Category 1 it's an emergent needs to be seen within 15 minutes. Type category 3 is an urgent case and needs to be seen within 30 minutes and so on. والكل واحدة منها في كرايتيريا معينة هنا تشوفونها مكتوبة. فأول ما يجي البيشنت في نيرس في التراياج تشوف الفيتال ساينز وتشوف هل هي تقع في أي فئة وعلى أساسها يعطى البيشنت triaging number and that will eliminate how fast he should be seen. Okay. هاي باختصار triaging system. زي ما قلنا أهم شيء إحنا عندنا إنه ال initial treatment is directed toward the physiologic derangement يعني shock نقول هذا عنده shock rather than what might be the underlying cause sepsis مثلا. لما نقول respiratory failure as we said this is the most common cause of cardiopulmonary arrest in children. لما نقول failure it means it's inadequate oxygenation فكلينيكلي بنشوف انه نقص في الاكسجين عنده desaturation or and inadequate ventilation. الفنتيليشن معناته CO2 removal. الواحد ممكن يكون عنده مشكله بالاكسجينيشن بس ما عنده مشكله بالCO2 level او ممكن يكون عنده مشكله بالCO2 level initially بدون مشكله بالاكسجينيشن او ممكن يكون الاثنين مع بعض. فاي واحده منها تعتبر respiratory failure. فkeep in mind انه respiratory system function is oxygenation and ventilation. Oxygenation is giving you oxygen, ventilation is removing the CO2. But either this or that could be affected. It may be caused by intrinsic lung or airway disease. فممكن يصير في lung parenchyma فيها مشكلة زي النيمونيا، يمكن يكون airway disease زي الأزمة، airway obstruction بالforeign body aspiration أو croup or poor respiratory effort resulting from central nervous system dysfunction. يا واحد يجي hit trauma، يا واحد ياخذ medications تخليه apneic، كل هذه ممكن كلها تسبب respiratory failure. It's usually preceded by respiratory distress. So you will see signs of increased work breathing. You will see tachypnea, you will see nasal flaring, you will see intercostal muscle retractions, grunting, accessory respiratory muscle use. كل الأشياء اللي شرحناها بالrespiratory examination. هذه في الغالب. إلا إذا كانت المشكلة طبعاً عن طريق السينس dysfunction, you will not see signs of increased work breathing. Shock, by definition, it's a physiologic state with insufficient delivery of oxygen and metabolic substrates to meet the metabolic needs of the tissue. And delivery does not meet demand. في احتياج للأكسجين، في احتياج للنيوترينتس. إذا الدليفري هذا doesn't meet a need, this is a shock state. Clinically, you will see it as inadequate tissue perfusion. So that will be as a pallor, cold skin, poor pulses, delayed capillary refill, oliguria, and abnormal mentation. إذا قل البرفيوجن للأعضاء المهمة الجسم وش بيسوي؟ يحاول إنه يحافظ على الفلويدز في الجسم. محافظة الجسم على الفلويدز في الجسم راح يقل اليورينيشن فيصير عند البيشنت أوليغويوريا. يقلل البرفيوجن للأعضاء ومن ضمن الأعضاء هذه البرين. إذا قلل البرفيوجن للبرين يصير عندك low Glasgow coma scale أو low level of consciousness. Okay. زي ما قلنا it is classified shock as compensated or uncompensated. When we say compensated معناته normal blood pressure. When we say uncompensated معناته low blood pressure. طيب, what is the sign we see here for skin? What we call the skin appearance. and when do we see it? في أحد عنده فكرة؟ ها شباب؟ ما في مشكلة. هذا نسميه mottled skin. اوكي، mottled skin. المottled skin يصير زي كذا، في بقع بلانشد، ما فيها، ما المفروض كله يكون لون واحد، في شبه من رينو صح؟ هذا ممكن تشوفه في الشوك. so this could be due to shock، انه بدا يصير vasoconstriction peripherally. لكن اوقات ممكن تشوفه في الانفنتس due to cold exposure، اذا كانوا في غرفه بارده، لانه الاوتونوميك سيستم عندهم ما هو fully developed، فتصير بعض المناطق يصير فيها vasoconstriction وبعضها ما يصير فيها vasoconstriction. you could see this in the normal babies أو normal infants with the cold exposure أو في حالات الشوك. if you see it, you should examine or complete your physical examination to make sure that this is not a shock state. اللي هنا what do we call this? If you blanch skin and then you see it like this. هذا capillary refilling. Normally إذا blood pressure is okay والperfusion is okay، إذا ضغطت على السكن بتصير أبيض طبعا، إنك you remove the blood من capillaries. بس as soon as you remove your hand off it should fill back، يرجع لونه طبيعي خلال أقل من ثانيتين. إذا تأخر أكثر من ثانيتين this is abnormal، معناته في low perfusion. if you have a cap refill time more than 2 seconds this is abnormal. Okay. طيب عندنا 4 types of shock اللي هي hypovolemic, distributive, cardiogenic and obstructive. So can you tell me what is the primary circulatory derangement في الhypovolemic؟ وش يصير عندهم؟ وبعدين ناخذ common causes as an examples. what is the primary derangement or primary pathology? Excellent. Decreased circulating blood volume. Causes. Mention some causes. Anything that comes to your mind. Bleeding, excellent. So this will be hemorrhagic shock, bleeding. What else? What do you think is the most common cause for hypovolemic shock في children? لا طبعا trauma will cause bleeding، بس البليدنج ما هو most common cause، ما هو أكثر سبب شيوعا نشوفه. What do you think? Dehydration. Excellent. Dehydration due to gastroenteritis. Gastroenteritis is usually the most common cause of dehydration, and it could cause hypovolemic shock. Other causes that may cause dehydration: diabetes insipidus ولا diabetes mellitus، كلهم بيسببون increased urination and it will cause dehydration. Malnutrition can as well بيسبب لك capillary leak. البيرنز يصير فيه fluid leakage. والادرينوجينيتال syndromes. طيب distributive، وش قصدنا بالdistributive؟ وش يصير عندهم pathophysiologically؟ إن الهايبوفوليميك يصير عندهم decreasing blood volume. distributive وش المشكلة الرئيسية عندهم؟ يصير عندهم vasodilation. اوكي، يصير عندهم vasodilation. إذا صار عندهم vasodilation كأنه فعليا الفوليوم قلت. واضح؟ it's a relatively low volume لأنه زاد الحجم. They have vasodilation. Once they have vasodilation, it will be in shock state. Examples طيب للdistributive اللي يصير عندهم vasodilation: طيب ممكن يكون some drugs that cause vasodilatation، صح؟ What else? Allergies، صح. Anaphylaxis. Sepsis لا تنسونه، ممكن يسبب لكم distributive. Anaphylaxis اللي هي الانرجي. Sinus or spinal cord injury with drug intoxication. Excellent. الكارديوجينيك the main problem من الاسم كارديوجينيك فالcontractility. اوكي، الcontractility is affected، فالهارت مو قادر يضخ كمية الدم الكافية فيصير عندهم شوك. الاكزامبلز اللي لها congenital heart disease في children's، heart failure، arrhythmias، myocarditis، some drugs or metabolic derangement، hypokalemia والاشياء هذه، hypocalcemia، كلها ممكن تسبب decrease بالcontractility. الobstructive المين issue it's the mechanical obstruction للventricular outflow. اوكي، ففي obstruction يمنع الدم انه ينضخ بشكل كافي من القلب. Examples: can you give me some examples of obstructive? cardiac tamponade، pulmonary embolism، tension pneumothorax، كل هذولي are examples of obstructive. فمهم انكم تعرفون تقسيمات هذه للشوك والاكزامبلز اللي لها. لا، الايروي اوبستراكشن ما راح يسبب بشكل مباشر. هنا فيه كيف احنا نفرق بين الكومبنسيتد versus الهايبوتنسين شوك. ما هو مطلوب منكم تعرفون الارقام هذه، just to make it easier for you. okay. I already say it. Now let's go with the examples, okay? 6-month-old girl is brought to the emergency following 1 week history of nasal congestion, cough, wheezing, post-positive vomiting, tachypnea, and fever. On arrival to the emergency, vital signs: heart rate 180, respiratory rate 70, pulse oximetry 87 room air, and temperature of 38.7. She's tachypnic, grunting, retracting, and cyanotic. Which is the child's physiologic state. لما نقول stable معناته كل الفيتالز within normal. So what do you think? Excellent. Yes, Basil. Impending respiratory failure. Very good. طبعا we cannot say انها shock لان ما عندنا any information about the cardiovascular system هنا. We didn't mention blood pressure, we didn't mention perfusion. All we know is about respiratory. But it's not cardiopulmonary at all, and it's not shock. It is impending respiratory failure. Correct. طيب, a previously healthy 4-month-old girl presented to the emergency with a 4-day history of vomiting, loose watery stools, and low-grade fever. She became lethargic 24 hours earlier and has refused to drink water or milk. What is the likely etiology of shock in this child? Be careful. Is this distributive? Distributive معناته عندهم vasodilatation. زي ما قلنا زي some drugs intoxication, anaphylaxis, spinal cord injury. هذا البيشنت عنده vomiting diarrhea. فتمام عليك باسل. This is hypovolemic. He has a dehydration. He's losing fluids. He's vomiting and he's having diarrhea. And now he's in dehydration, hypovolemic shock. Why is she lethargic? What could be possible reasons that she is lethargic? Okay, dehydration causing shock. So that's why there is a decreased perfusion to the brain. Correct. That could be one. Don't forget, refuse to eat or drink water or milk, but this could be hypoglycemia because this child didn't eat or drink for the last 24 hours. But this could be hypoglycemia. That's why she is lethargic. Or due to gastroenteritis, could be having electrolyte imbalance that's causing lethargy. What are other signs of shock that you might find? What would be possible other signs of shock that you will see? طيب low blood pressure, correct, if this is decompensated shock. Level of consciousness صحيح, decreased level of consciousness. يصير عندهم oliguria, decreased urine output. What else from perfusion? If you examine the hand, what would you see? Notice what do you mean by less? طبعا النورمال اذا ما كان في شوك الكابيلاري ريفيل will be less than 2 seconds. بس اذا في شوك بيصير يطول, بيصير more than 2 seconds, بيصير 3 seconds, 4 seconds, 5 seconds at times. The pulses will be weak, so you'll have weak pulses. Well, preference could be cold, okay? How will you manage this child? طبعا if he is in shock, ABC صح, correct. You make sure that his airway, breathing are good. And then circulation, he is in shock, you will give him fluid. So usually we will be giving him fluid bolus, okay? It's 20 ml per kilo. And it's always normal saline, okay? We don't give bolus of anything else other than a normal saline. If you want to give a bolus, it's always normal saline. Then you will start him on the fluid طبعا maintenance plus deficit زي ما ناقشناها قبل في الفلويدز. How would you make it your management different if the initial sodium is 170? You will make a correction very slow. Why? Because you don't want to drop sodium very fast. If you drop sodium very fast, it will cause cerebral edema, okay? Clear? خلينا ناخذ السيناريو الثالث. Badr is a 5-year-old boy known to have asthma on Ventolin inhalers as needed. He was brought to the emergency with 3 days history of cough and upper respiratory tract infection. Today, he developed shortness of breath, and so he was given Ventolin and brought to the emergency. Vital signs upon arrival: pulse 110, respirate 35, temperature 36.5, pulse oximeter 93 on room air. The chest exam reveals good entry with scattered wheezing. What's your impression about the physiologic status? So all his vitals are within normal, so he's stable, okay? So he is stable. So let's say, how would you manage him? This is an acute asthma exacerbation. Ventolin, exactly. So you would give him Ventolin. So let's say after 2 hours, a nurse inform you that the vital signs are pulse 130, respiratory rate is more, temperature is still stable, and oxygen saturation is less. What's your next action? Why he's now with the Ventolin, he's more tachypnic, and his saturation is decreasing. What do you want to do? ABC, excellent. So you will examine him again. So let's say on a breathing, when you auscultate, there's decreased air entry on the right side. Why do you think he has a decreased air entry now? طيب, one is that it's possible that his first initial presentation was due to foreign body, not really due to asthma. This is possible. What else? Let's say no, his first presentation or his assessment of asthma is pneumothorax. Excellent. ممتاز يا معتز. Yes, this is very possible. Pneumothorax is a risk factor في acute asthma exacerbation because they can get the air in easily, but it's very hard to exhale. فبيصير تجمع للهواء يزيد 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 كأنه بالونة بعدين it will burst. فيصير عندهم تسرب للهواء في النيمو في البلورال فيصير عندهم نيموثوركس. ف very good suggestion and very good thought. This could be a foreign pneumothorax. So you should get an X-ray to see if this is a pneumothorax or not. Excellent. طيب, next scenario. A 3-month-old girl with a history of ventricular septal defect, VSD, presented with 1 week history of progressive tachypnea, diaphoresis مع تعرق بزيادة, weight loss, and decreased urine output. Her mother indicates that she had run out of medication. Examination reveals that the child is grunting, tachypnic, and diaphoretic. She has a loud pericardial murmur and enlarged liver. She will be sent from the clinic to the radiology department for a chest X-ray. Your next step in management is, do you want to wait to see the X-ray or send the child to the cardiology clinic the following week? I'll give 20 ml per kilo of bolus. I'll give diuretics and consider starting inotropics. Excellent. So this patient is actually in a heart failure. Well, heart failure and it's a cardiogenic shock, correct? So you don't give fluid. This is a lot of fluid. 20 ml per kilo is a lot of fluid, and you will make the cardiogenic shock worse. But it's better that you give them diuretics to decrease the load in the heart. And if you really need to support the heart further, you would give inotropes to improve the contractility. طبعا keep in mind إنه الهارت failure صار عندنا left side و right side. left side failure بيصير باك اب للفلو، بيرجع الفلويدز لللنجز فبتسبب pulmonary edema. البلمونري edema بتسبب تكيبنيا، ونفس الشيء بالفيزيكال اكزامينيشن الجرانتنج. الرايت سايد فيلير بيرجع الفلويدز يسوي congestion في الليفر فيصير عندك enlarged liver. هنا enlarged liver is a sign of right side failure، والتكيبنيا والجرانتنج is a sign of left heart failure and pulmonary edema. طيب, this is good. طيب, a 2-year-old brought to the emergency 2 hours following ingestion of the grandmother medication. He's lethargic and becoming more drowsy. The parents do not know the medication name. Your colleague suggests to rush the patient for gastric lavage. What would be the best response to your colleague? طبعا احنا تكلمنا عن gastric lavage في المحاضرة الماضية. وقلنا الانديوست فام صح بالضبط يا معتز. قلنا الانديوست vomiting والgastric lavage we don't do them anymore في pediatrics. But because now he's drowsy, he may lose his airway reflexes. So the priority is to secure the airway. Any time that you see somebody who's having deteriorating level of consciousness, you should protect the airway. So the correct answer here is D. How will you secure the airway? By intubation. What advice you will give the parents in the future? That they should really keep the medications out of the reach of the children, okay? طيب, next scenario, a 5-year-old boy is brought to the PICU from a referring hospital where he presented 5 days ago with fever, swelling of the left knee, and redness. He was treated with ceftriaxone and acetaminophen. He became oliguric, tachycardic, and hypothermic, and received 500 ml of normal saline prior to the transfer. On arrival to the PICU, he is found to be lethargic, hypothermic, hypotensive, and tachycardic. What is the likely etiology of shock? Excellent. This is septic shock. What type of shock is this? Septic shock. How can you determine end organ perfusion? طبعا clinically مثلا kidneys by urine output, brain by level of consciousness. Other organs you could by labs. Okay, you do CBC. احيانا بيصير عندك CBC فيها pancytopenia if the bone marrow is affected. Liver enzymes will go up if there is an injury to the liver because of the low perfusion. How will you manage him? If he's still in hypotension, you should give a fluid bolus. So again, you'll give him 20 ml per kilo. Okay, so you get fluid boluses, up to 3 fluid boluses. If it's not enough, you will start anitropes. And I agree with you. You would do a culture and start empiric antibiotics. Excellent. طيب, هنا different scenario to bring your attention to something else. يعني it is probably the same but different presentation. I had exactly the same patient, but the examination هنا is slightly different. He's warm and have warm peripheries. He's hypotensive or tachycardic, but the capillary refill is less than 1 second. So it's brisk. When we say brisk, ما حتى ما تشوف البلانشنج. يعني لما تضغط على اليد المفروض إذا شلتها تشوف شوي بياض بعدين يتغير يرجع مرة ثانية الأحمر. لا, هذا بمجرد إنك تشيل يدك على طول يرجع أحمر سريع مرة. Why is that? So this is actually again correct. It's a vasodilatation, Mu'taz. So it is actually again a septic shock. Okay, a septic shock, but its mechanism is different. It's vasodilatation, correct? So we have 2 types of septic shock. في what we call cold septic shock وفي warm septic shock. The cold septic shock يصير عندهم vasoconstriction. Okay, إذا صار vasoconstriction يصير عندهم cold peripheries, weak pulses and delayed capillary refill. هذه في الكولد. الwarm septic shock يصير عندهم vasodilatation، يصير عندهم warm peripheries من الاسم، عندهم breast capillary refill، وعندهم bounding pulses. اوكي، فما هو weak pulse، يصير bounding pulses، تحسه يضرب بيدك، يصير قوي البلس. ف we have two different types of shock. Okay. The initial management is the same: ABC, fluid culture, antibiotics, but the choice of inotropes is different. هنا بنعطيهم شيء يسوي vasoconstriction. Okay. هناك نعطيهم شيء to improve the cardiac contractility. فهناك في الcold shock نعطي epinephrine، في الwarm shock نعطي norepinephrine. ما يحتاج تعرفون هذه التفاصيل، أهم شيء تعرفون التفريق، وإنه في two types of shock اللي هي septic shock: warm and cold. Okay. طيب عندنا 2-week-old girl arrives by ambulance to the emergency from her home, where she was found to be apneic. On arrival, heart rate is 200, blood pressure is 40/20, and she is hypothermic with no palpable pulses in the lower extremities. ما عليكم what type of hemodynamic status, because I want to ask you about it. But you're right, it is hypotensive shock. It is. But what is the etiology of this shock? What do you think? Excellent. So this is a case of coarctation of the aorta. That's why there is no palpable pulses in the lower extremities. So the hint here is no palpable pulses, plus the age. What is the medication that you should immediately administer? هو الميديكيشن الوحيد اللي نعطيه في الكاردياك كيسز to save them. What is it? Prostaglandin. Yep. So prostaglandin. We should give a prostaglandin in this case. The prostaglandin will open a PDA, and this will perfuse areas beyond coarctation. Okay. طيب عندنا 3-month-old girl with history of colic is brought into the emergency by a relative with a history that the infant apparently fell from the crib to the floor. On physical examination, she is unresponsive to stimulation, and she has multiple bruises to the head, chest, and abdomen. What do you think of this? Right, because we have here multiple trauma, multiple bruises. This is one concerning, and the other concerning sign is we know at 3 months they don't flip. They couldn't fall off the crib. Don't worry about the management. طيب هذا آخر scenario. 4-year-old boy has been admitted to the ward with the diagnosis of uncomplicated pneumonia. 10 minutes after receiving the first dose of IV antibiotics, started complaining of tightness of chest, not feeling well. Upon arrival to his bedside, he's unresponsive. with labored breathing, audible wheezing, appears flushed and has urticaria rash, swollen eyes. He's warm, tachycardic, and has bounding pulses, and his blood pressure is 70/20. Excellent. So you should, this is what type of shock? Anaphylactic, so it's distributive, صح? Due to anaphylaxis. So it's distributive shock due to anaphylaxis. He's having vasodilatation. So you need something to improve this. So you would give epinephrine IM, correct. If you see blood pressure في الwarm shock ولا في distributive shock, diastolic blood pressure is low دائما. هنا diastolic pressure is 20 only. هذا بسبب الفازوديليتيشن. اوكي. عشان كذا يصير عندهم bounding pulses. البulse pressure اللي يحدد كيف احساسك بالبulse هو الفرق بين السيستوليك والدايستوليك. فهنا عشان الدايستوليك قاعد ينزل فيصير الفرق بين السيستوليك والدايستوليك big. So that's why you have bounding pulses. Okay. العكس يصير في الفازوكونستريكشن. في الفازوكونستريكشن يقل الفرق بين السيستوليك والديستوليك فيصير عندك weak pulse. Okay.